So I have the great pleasure to introduce Mike Brauer. He's a professor in the School of Population and Public Health here at UBC and also a faculty associate at IRES. And in addition, an affiliate professor at the University of Washington, where he leads a team doing research on global burden of disease. His research focuses on linkages between the built environment and human health with some specific interests in global health impacts of air pollution and health impacts of a changing climate. He has served on numerous advisory committees at the national and international levels, received numerous career achievement awards and publication awards. We don't need to go into all that because we're all keen to hear his talk on estimating the global health impacts of environmental risk. Thank you so much, Megan, especially for this impromptu forum.
Thanks, Stephanie. This is kind of fun because I've never done it quite like this. It's very intimate. It's very nice. Let me just plug this in. I was going to say somebody could sit right here. Could really be very, very nice. Well, welcome everybody. Welcome everybody on Zoom. Just first of all, I can do a show of hands actually of the people in the room. Who's heard of this book? Who's read this book? Okay, well, I've read it. I really encourage you, especially trainees, students, to read this book because it's actually geared towards your generation, not my generation. But it really speaks to kind of what I do. And it's all about data. And it's really trying to say, if you look at the data, there's some really good stories. And we should not forget the good stories. Data puts things in context, it gives you perspective, and when you see those good stories, that should all give us hope. Doesn't mean the work is done, it doesn't mean there's a lot of challenges ahead, but it's really easy to get caught up in bad news. And I say this to my students all the time. I actually started out learning journalism. We were taught as journalists to be objective. That is certainly not the case anymore. Journalists are usually not objective. They're trying to sell things, they're trying to draw attention. And one way they do that is to try and shock people and one way to shock people is to give them bad news. So we see that repeatedly. We see that a lot actually in the work that I do. There's very rarely reporting on the good news about how things have actually improved for much of the world's population, let's say in terms of access to drinking water, access to clean, to sanitation. Of course, the job is not done, the job will never be done, but there's a lot of success. And we need to think about that when we think about the challenges that we're facing in the future. If you go back 100 years and you looked around and you said, oh, it's doom and gloom, we would never have had those successes that we have today. So, and that's really the message in this book. And I would also just, a little bit of opinion here. Keep in mind also that activists have an agenda. I mean, activists are great. There's a need for environmental activism. They certainly have a place, but they also have an agenda and they're biased almost by design, right? Because they are trying to get you to do something. So again, sometimes activists will do the same thing and not look at data. Some of the better activists do sometimes those data, and there's examples I can give you where environmental NGOs have actually ignored the data to suit their own purposes. So look at the data would be my plea. And that's really sort of the focus of what I'm going to talk about, is sort of using the data and also some of the challenges and limitations when we have data to try and answer these questions of what is the impact of the environment on health of populations. So I am not the first to do this. I think if you don't know who Hans Rosling is, started the website Gapminder probably 20 years ago, really the first sort of proponent of looking at data to understand actually how the world was functioning, the good, the bad, the ugly. We have websites like Hannah Ritchie works for Our World in Data, things like the Yale Environmental Performance Index. And then what I'm going to talk about is a project called the Global Burden of Disease, which is really a data project. We also have Canadian data sets, something called Canoe that I know many people in IRES have used. So this Canadian Urban Environmental Health Research Consortium or something like that. I don't know, I've been working on that for like 10 years. CareX Canada is something about carcinogens. So we have, and we actually are blessed with a lot of really excellent data, both in terms of environmental exposures, environmental concentrations, as well as health impacts in Canada. So that's, yeah, end of opinion. So when we talk about environmental, see, I want to look at the screen and it's black, eclipse, right, or something. When we talk about environmental risk factors or environmental hazards, there's thousands of them. If we think about it like chemical by chemical, compound by compound, many challenges. We think about all the ways the environment can impact our lives, what we eat, what we drink, when we go outside, the buildings that were built, that we're spending time in, what do we do with our waste, how do we cook our food, how do we grow our food. All of these are ways that our health can be impacted. So one real challenge is actually how do we prioritize? How do we prioritize in terms of action, but even on the research side? And that's really a little bit of kind of my story. I've spent most of my career, and now I have sort of two jobs, and I'll tell you kind of why, but much of my career has been sort of doing the detailed studies. So we've made measurements of all kinds of things all around the world. We've done extensive measurements in Vancouver, throughout Canada, both in environmental concentrations of air pollutants, temperature measurements, noise measurements, chemical exposures, linking that to health data and getting those relationships. And so, you know, I've got hundreds of papers on those kinds of relationships. And I learned a lot. So I could, you know, tell you what this does and what that does and how many people are affected by this and that. But I was still kind of frustrated because kind of making that data actionable was a real challenge. And so we have study after study after study after study. And unless I'm giving a talk or unless I'm being interviewed in the media, getting that message out was really challenging. So we know a lot. In fact, we know enough to act on most things that really matter. That's a really important point. It's not actually an issue of sort of non-understanding things. It's really getting the message out in a way that's impactful. And that's why I got involved in this project called the Global Burden of Disease. It's a project that fundamentally was trying to estimate health around the world. And I'll show you a bit more detail about that in a second. In Canada, we have a really good idea of the health of our population because we have vital registration. So every birth is recorded, every death is medically certified, there's a cause of death. And in fact, we're really blessed because we have a universal healthcare, and because of billing, every contact an individual has with the healthcare system is recorded. It's not recorded for research, it's recorded because so that a physician can get paid. But we use that a lot for research, and it really gives us a good way of understanding the health of our population. Not true in many countries of the world. So around half the countries of the world do not, or even more, don't have vital registration, meaning that when somebody dies, maybe that death is counted, but there's absolutely no information on the cause of death. And then many countries who will even have some cause of death information, it's not medically certified. So it's usually you'll get sepsis deaths. It doesn't tell you anything about what infection that was, or heart stopped, which kind of that happens when you die. And that's just death, let alone, really what's more important is actually health when you're alive. We all have to die. And so this project was really fundamentally trying to look at that for everybody around the world. So we can actually have a picture. And if you don't, you know, this is sort of my mantra is, if you don't know it, you don't know what to do about it, right? You're making guesses. And again, there's all kinds of examples where foundations, NGOs make stuff up to suit their own interests. And again, these are good interests. Nobody's saying that, you know, maternal mortality is a bad thing. But if we don't know what proportion of health loss that is causing, and disproportionate amounts of resources are going to that, we're actually not solving the problems that matter. And that's really the goal of this project. And then I'll tell you sort of where environment comes in. So it's about, so why do we want to know? Well, we want to be able to prioritize both in terms of what's happening right now, what's happening, how do things vary around the world? And then what about the trends? When we've implemented policies, do they actually work? So how do we track whether things are working? How do we actually identify new challenges so we can actually start to plan for the future and not be reactive? Pandemic is a great example of that. We were not prepared. It's not as though people were absolutely silent about it, but you can imagine if we were better prepared, at least the first year would have been a lot easier. I'm not saying like actually that, 3 years and how many people would be dead or alive, but we would have actually known what to do about it. So thinking about what we actually need to prepare for the future. And then the work that I do is really trying to think about the causes. What is actually causing things to change? So why are people affected? Is it what they eat? Is it what they breathe? Is it what they're doing? And it also gives us a better understanding of actually what those disease processes are. So we can ask questions like, what is the total impact of disease and injury in the population? Which diseases are most important for which groups? Very simple questions. Are things getting better or worse? And again, if you follow the media, you do not get a complete picture of it. How do we compare the impacts of different risk factors? So how much of disease burden is due to environmental factors? I mean, really, if you're working on some environmental issue, you ought to know that. And I'm not saying you ought to know because you're not doing your reading. We actually don't know in many cases. So why are we doing it if we don't know about it? And then we'd like to know for questions like, what about air pollution versus tobacco smoking? And you can see, obviously, if government's going to fund programs to deal with tobacco smoking and air pollution is worse for the population, maybe we need to redistribute resources. Or if you've been so successful, and this is also really interesting in terms of how governments function. If you've really been successful, maybe you've gotten things down to 2% of what they were a decade ago. It's really hard to let go. But actually, that's when you should let go, and you should be shifting resources. So we actually don't do well with sort of recognizing successes and then actually moving things around. So this is this project. It's systematic, it's scientific. We want to quantify the magnitude of health loss due to diseases, injuries, and risk factors. Do it broken down by age, by sex, by geography, and time. So it's everything. And so now there are some sort of 600 or so people sort of nominally based in Seattle, but it's really all virtual that are working on this. A network of collaborators of about 12,000 people around the world. It's the largest research project actually in the world. The vision is that everybody deserves to live a long life in full health. And we want to identify what's preventing populations from doing that. And again, you can't save lives if you don't know what people are dying from. You can't make people healthier if you don't know what's making them sick. And just to give you a sense of when we talk about health, when I teach this, I sort of like to say, everybody's had a moment or so, or hopefully several moments in their lives when you've eaten well, you've had a good night's sleep, you're not stressed, you're just feeling great. Those are fleeting moments. That's full health. It's really rare. So we are all living, myself included, in a state of incomplete health. But that doesn't mean we shouldn't be striving for everybody to get that all the time. It's never achievable, but we can all think about, there's a time in my life, there was a day, there was a moment, a minute that I felt great, and that's health. We're never there. In this project, we also have, I won't belabor this, but again, it's data. We want to do things comprehensively. We want to communicate when we know things well and when we don't know things well. And why is that? Well, if we don't know things well, that's where we want to actually do more research. That's where universities come in. We want to make sure that things are consistent. So if I'm telling you 6 million people die every year from smoking, that's using comparable methods to the ones that I can say, 1 million people are dying from lead exposure. So I'm not doing apples and oranges comparisons, which is actually what happens in most of our work outside of a project like this. We're improving things all the time. So we're just about to release a new set of data from up to the year 2021. The one prior was up to 2019, but we redo the whole time series starting from 1990. So, and that means that we've got new data, we've got new methods, and we're always trying to make it better and better and more accurate and more precise. Trying to use all the data that are available, correct for errors. So just to give you an example, depending on where you live, not just in the world, but even in North America, you will die in one way and your death will be coded differently. So nobody is, for most of the time that people die, nobody's really doing a detailed autopsy. That's very unusual. So the physician that's there decides what you die. But there are rules that they follow, but there's a historical context. And we've actually seen racial differences. We've seen geographic differences, despite there being rules about this that individuals that are doing death coding follow. So we want to actually correct for those. So again, that we're doing like-to-like comparisons. And again, that's a challenge. So I keep mentioning death. Death is really easy to measure, even though I just told you there's complications with it. But yes, you're dead or alive. But really, that's not a very good indicator of health because, as I said, unfortunately, we all die someday. What's more important is actually what about when we're alive and when that death may occur and how many years of life potential that you may have lost. So actually, this project many years ago came up with new metrics. And you probably have heard of something called the disability adjusted life year. Who's heard of that? Dallies, everybody. Oh, that's great. So I don't have to explain what it is. But it's really a year of unhealthy life, okay? And again, I'm telling you, everybody in this room has some unhealthiness in their life all the time. So we want to, again, improve that. So these are just the measures. So there's really 4 building blocks, and I'm just rushing through this because I want to show you results. That's really the purpose of today. So all-cause mortality, which is just numbers, how many people died. Sorry, Malin, like screen broke, so you got to be right here. So all-cause mortality. So that's just numbers, dead or alive, and that is pretty easy to measure. It's something that we now have for I think there's 204 countries or territories in the world that we measure in, which is, I don't really, actually getting an accurate number of countries is not a simple task. There's disputed territories and all kinds of things, but it's about the total. And we have all-cause mortality for about 100, 110 or so of those countries. So about half, we don't even have that, just counts. But then we want to know causes of death. So actually, like we have in a country like Canada, who died of what? And we also want to know about non-fatal outcomes. So who is sick and what are you sick from? And then the work that I do is what's causing the death and the sickness. So what are the risk factors for that? And again, something like all-cause mortality is relatively simple. As I said, we have that maybe for around half the countries of the world. Causes of death, we very, very limited number of countries and limited. So a lot of this is, we model this. And we model based on our understanding of diseases. We model based on if we know something about one country and we have information on a nearby, or we don't have information on a neighboring country that's similar in terms of socio-demographic status, we'll borrow information from nearby countries. We'll borrow information from nearby points in time. Again, we try and use all the data that are available to come up with the best estimates. But as I said, when things are uncertain, we're not hiding that. And really important, so those of you who are generating data, please, please, please generate your uncertainty as well, because that's what tells us where we need to actually do more research. We need to do better. So it's not all about the mean or the median. It's actually about, you know, how well do you know that? Okay, so I said 204 countries and territories, and we do subnational analyses in many, and now I think all countries over 100 million people, we're doing subnational, so at the state or even finer levels of resolution. We estimate this by age, lots of different age groups, by male, female, both sexes combined. So we have about 370 distinct causes, and there's sequelae, so what happens if you have something, and 88 different risk factors, so those causes. And here's just a list of how we sort of organize the diseases and the injuries. And this is just at one level of sort of, we aggregate to communicable diseases, non-communicable, and injury, and then we just continually get more and more and more detailed at different levels of resolution. So then this risk factor. So what are we doing about environment? So to do that, we really need to know 3 different things. So this disease-specific burden is what I just showed you. How many people die, how many people have strokes every year, et cetera, et cetera. Again, that's a whole modeling exercise, but to understand something like radon exposure and lung cancer, we need to know how much radon there is, so how much radon people are exposed to. We need to know the relationship between radon, so a level of exposure of X is linked to a level of lung cancer of Y, so that relationship. And that's all the kind of work that I've done for most of my career, just doing those studies. So we measure radon in thousands of homes, we look at lung cancer rates, and we come up with a statistical relationship. So we need to know those 2 things. And now you can see how it's challenging, right? Because if I said something like bisphenol A, we may have a handful of studies, but I'm going to ask you, what about a 60-year-old woman living in Dakar? What's her bisphenol A exposure? Hell if I know. Hell if anybody knows, right? So I would love to be able to do that, but that's a really challenging thing to get, even to model that. So we need to know that. We need to know that relationship. And then we also want to know an optimal level. So an optimal level for something like bisphenol A exposure should be 0, because that's something we're artificially adding to our bodies. Blood pressure, optimal level is not 0, right? So that's a little bit challenging. And for many dietary factors, even something like sodium, for example, you need sodium. So how much is optimal? So that's a little bit challenging. And even something like air pollution, we won't get to 0. There's volcanic eruptions, there's sea salt that contributes to particles in the air. So trying to understand what actually is the optimal level. So, but something like smoking, something like bisphenol A, you can imagine a world where nobody smokes. So we're making that comparison all the time. So getting those 3 quantities is challenging, but if we have that, then we can calculate what's called a population attributable fraction. And that's telling us basically how much of the disease, so how much of that lung cancer is due to radon exposure. How much of that lung cancer is due to air pollution, how much of that lung cancer is due to smoking. And we basically just multiply that fraction by the number of lung cancers, and then we say this proportion of lung cancer or these numbers of lung cancer are due to radon, et cetera. So that's what we're doing. So here's the risk factors, and here's results. And how am I doing on time? How am I doing on time? 7 minutes. Oh my God. You got to give me 5 from the, was that from when I started or? Oh my God. All right. Well, all right. I'm going to zip through these. So unfortunately, because of time, because of timing, I can only show you slides of the actual results from our latest release. You can go to a website that's GBD, Global Burden of Disease Compare, and it will at least give you the results from our last release, which is 2019. It's a super website. I don't have time to show it to you. It's interactive data visualization. But this is sort of, so a couple things. So one is that we know for like all the disease in the world, we can attribute about 45% of that to these risk factors that we estimate. So there's a whole bunch that we're not, and some of it we never will. So some things just happen by age, or we don't really deal, I mean, we're starting to, but we don't really deal with genetics, for example. So we're only getting, maybe half-ish or so from the kinds of things that we model. And then, there's things like that we would like to include, like something like bisphenol A, but we don't, right? So everything I'm going to show you is based on, this is the best that we can do, but this is sort of a limited understanding. So this is just one visualization. And this is basically the size of the square is telling you globally what people are dying from in the year 2021. You can see this big red square here. Well, you can't see it because it's small. That's COVID. And so that was a rather unique year. Everything in blue are non-communicable diseases. Everything in red are communicable diseases, and the green is sort of injuries. So you can see if you remove COVID for a minute, just don't look at it. Ischemic heart disease, which is heart attacks, stroke, and chronic lung disease here are the biggest killers in the world. What you can see here, the darker shading is how much of that is now accounted for by, in this case, environmental or occupational risk factors. So we're getting somewhere, again, if I could do this online, I could hover over this and give you the exact percentage. But we're something like a quarter of ischemic heart disease, a quarter of stroke, about 50% of chronic lung disease and about 80% of diarrheal disease. So, some big killers. This is pneumonia, lower respiratory infections. Some big proportions of some big killers are contributed by environmental factors. And I'll show you sort of another one that's sort of very topical, is Alzheimer's or dementia. We're starting, and it's just something where we're just starting the work now, but when we add in environmental risk factors, we will probably be getting like 20 or 30% of that. So some big causes. COVID's a great example. We don't account for any risk factors because, we're still unclear, actually. We don't know exactly what the relationships, let's say, with obesity and COVID is, for example. So now this is global. I'm just going to flip between, this is Canada, and I just picked Somalia. So what can you see here? Well, you can see the blue in Canada is a lot bigger than the blue in Somalia. The red in Somalia is a lot bigger than the red in Canada. So this is all non-communicable diseases, things like heart, lung disease, Alzheimer's, diabetes. Those are the big killers in Canada. In Somalia, it's still what I would call sort of traditional causes of death, things that we've largely eliminated in Canada and most high-income countries: diarrheal disease, lower respiratory infections, so pneumonia, neonatal deaths or maternal deaths, tuberculosis. And you can also see something that these have some pretty big environmental components, so the darker shading there. So this is just the ranking of the risk factors, and then we can answer that question. Does smoking kill more people than particulate matter air pollution? Yeah, but not too much more, for example. Where is unsafe water? And how has that changed from 2000 to 2021. Huge success story. Huge success story. Okay, so in terms of improving access to clean drinking water and improved sanitation around the world. Big success story with household air pollution. So this is cooking with low quality fuels in many low and still low and middle income countries of the world. Again, huge success story there. Unfinished work, but again, some things that we can and should celebrate. Same kind of thing with maternal and child health, low birth weight, huge success with that kind of around the world. So we can look at these kinds of phenomenon. This is just now looking at the environmental risk factors. So ambient air pollution globally, actually far and away, the leading environmental risk factor for death around the world. Household air pollution, second to that. Interesting, again, lead. Many people don't think of this. And if I ask most of you what you think about if I say lead, you'll think about IQ loss. This is actually lead's impact on heart attack. So lead actually affects your cardiovascular health as well. And that's lead that you've accumulated over your whole lifetime. So again, we can look at those globally. We can also look at the causes contributed. So how is particulate matter air pollution causing death? And it's not what people think. No time left. All right, I'm done. I'm going to take 5 more minutes, right? Most people would think it's lung disease. Mostly it's through heart attacks and stroke. Why is that important? Well, you may go to a lung specialist and they may understand that. If you go to a cardiologist and they don't understand that, they're not going to tell you, oh, you ought to be careful during a wildfire smoke event. Or if we're putting money into cardiac care, maybe we think about preventive approaches to reduce people's exposure to air pollution, that kind of thing. So again, Canada, Somalia, we can look at maps. I don't have time. Again, some success stories. So I just want to show you, this is a measure of socio-demographic, it's a socio-demographic index that we create. It has economy, female fertility, education in there. So it's our sort of best measure of, I would say, sort of human development. And you can see some sort of interesting patterns. So something like household air pollution, again, from that cooking, same thing for water and sanitation, incredibly well linked to the socio-demographic index. So as countries develop, those risk factors decrease. The absolute opposite is something like high cholesterol. So this is where we are at. So this is the sort of wealthier, more sedentary, poor diet countries of the world, which is where the whole world is going, mind you. And then we have something like particulate matter air pollution, which is a little bit sort of inverted U shape. Actually, the lowest income countries of the world really don't have that problem. It's when you sort of start to develop, you have motor vehicles, you have industry, you generate electricity. And then at some point, things start to decrease when they get too bad. And when governments actually have the resources to deal with it. And that's sort of where China is at, for example, right now. What else do I want to say? I don't have time to say anything. A lot's missing. So I mentioned that. This is, again, where students come in. You could do this research. If you can tell me how to estimate global pesticide exposure, like, come talk to me, because it's a challenge, because I've started to work on that. You may be able to help me. But it's, it's challenging, but, we think it's harmful, but we don't really know how to do it. We have studies showing that it, contributes to Parkinson's, well done studies, but I need to know how much people are exposed to around the world. I need to know that for arsenic, for mercury, things that we know are hazardous. And then what about those things that we're unsure about? Where we still need to do that exposure response research, like for bisphenol A or PFAS compounds. Just climate change, I just want to say that we're just at early stages for climate change. So one of the things we do count for is warm temperatures. And about 500,000 people died in 2021 just from warm temperatures, so kind of like the heat dome kind of thing. I will say that cold temperatures still kill 3 times as many people every year. And in Canada, it's the leading kind of environmental cause of death. And if you don't believe me, well, go spend a night outside, even tonight, when it's not in the middle of the winter, and you will not feel very good. Now imagine if you live in a poorly insulated home for your whole life. You can imagine how that will be. But we're starting to do more on climate change, and really what we're trying to do is, first of all, understanding where people live. So if you think about something like sea level rise, we don't know exactly where people are living. We can't actually estimate the impact of sea level rise. And we're really bad actually in knowing for most of the world where people live specifically. I mean, at like meter level resolution. So we're working now with Planet, which is a satellite company, and Microsoft AI to do a lot of complicated AI work to use human structures that we can get almost in real time from Planet. So they have a constellation of satellites that are giving, daily, multiple times a day. Human structures tell us where people are likely to be and where they're likely to move. We then disaggregate higher level population data from censuses or surveys. That tells us where people live. We overlay that with climate information, both currently and then using future scenarios. So like CMIP6 kind of scenarios. And that will tell us things like where in the world is it likely to be uninhabitable? We have historical information to say that if you have a mean annual temperature of about 30 degrees, now that's annual mean, people won't live there, mostly because you can't grow food locally and you can't work outdoors even to cultivate food under those conditions. So it tells us about where people will have to move from. It will tell us about migration, food insecurity, and then things like vector-borne diseases like malaria, where will that spread to? So we're working on that now, and I'm over time, so thank you. But if there's time to answer any questions, I'd be happy to do that. And again, look at that website. In middle of next month, we'll go live with the next release, and you'll probably see that in the media. Yeah, and you can look at the data yourself. So thank you. Yeah, we got to be out of here in 2 minutes. So, okay. All right.
It's all aggregate patient level. That sort of thing, and access to healthcare across income levels.
So all of the health stuff, so maybe that's a lot of questions there. So subnationally, we're doing every country that's over 100 million population is done subnationally, and then select other countries. And so in the UK, for example, we're at some very, very fine level. So that sort of depends, and it's really a resource issue. So we said, we'll do everything over 100 million. So Canada, for example, I've tried to get the Public Health Agency of Canada to say, we have all the data to do this by province, but they have to give it to us meaning the group at University of Washington, and pay for it. And they're like, we can do it better ourselves, which is actually true for Canada. So there's sort of decisions if they want to do it their own. And then income, so we stratify, we have this socio-demographic index, which does include, it includes an income variable as well as female fertility and education, which again, what we think are best measures of development. So we stratify by that, as well as World Bank income levels, some of the common things. Mostly that is sort of national, or again at those same subnational units. And then we use a lot of those other kinds of things that you mentioned in the modeling. And a lot of our modeling, so again, let's say lead, we have blood lead measurements from surveys around the world, but if we want to model in a place where we don't, we're going to use all kinds of variables like that to help predict. So, oh God. I told you to jump up and down. I'm telling you, right? The question was, you're fine. Okay, all right. It's like Jeopardy, right? Dan Malind. Yeah.
You can see the forward problem, which is you also have data on actually dying.
Yep.
How do you reconcile those? See that maybe that's where that gap of 45.
No, so the causes, so, oh, sorry. Jeez, it's weird how that brain does not work. So the question was, how do you basically bring in where you do have information about causes of death, I guess. So where we have that, we use it. So in fact, we actually buy lots of data from like healthcare providers to get access to data, not so much causes of death, because often that's available for free, but about hospitalizations and things. So we use that wherever we have it. But a kind of important distinction is that, so that's telling you stroke, heart disease, pneumonia. It doesn't tell you smoking. Smoking is never on a death certificate. And so people think that it is, but it's not. So none of these risk factors. So even though if you die of lung cancer and the physician interviews you and before you've died of lung cancer, says, have you smoked? Yeah, I smoke 30 packs a day and I have for the rest of my, and I'm not going to stop. And it's pretty damn clear that that was smoking. It's not on the death certificate. So there's no risk factor. And the heat dome is a really interesting example of that, which is kind of, so if you looked historically, we've had many, many heat events in Vancouver where statistically we see like not 700 people died, but 100 people died in each event. If you look back and see how many of those were like heat deaths, where there actually is a cause, there's like 2 in the last 30 years. What happened in the heat dome was because it was so obvious, then people requested that the coroner investigate all the deaths. And if there's a request made, the coroner has to. And so now we're going to have this weird statistical blip that all the deaths, the deaths that actually happen are going to be coded as heat deaths. If we have a heat event, this summer, that probably won't happen. So this is exactly the kind of stuff that happens. This is like, in Canada in 2021 and 2022, we're doing this. So yeah, that's why it's really challenging. Sorry, well, no, you're first. Sorry, yes, go, yeah. Well, I mean, we never want to let go, because, oh, sorry, letting go. God, I'm so horrible at this. The question was, when you've had success, do you let go? And so I was, a little bit flippant about this. So you have to be really careful about letting go, because if I hate the analogy, but I can't think of a better one. If you take your foot off, the brake, right, you still, and there's examples of that you sort of have to keep at it. But I mean, one global example, which is sort of is, and I work with UNICEF, so I'm not to say they're bad, but UNICEF has been really, really successful at showing people images of starving children and getting money that way. And you can see from the data that not just what UNICEF's done, but what many organizations have done, that's been successful. So maternal mortality is dropping, infant mortality is dropping. They're not going to stop that campaign. But what it means is that, you and I may be donating money where we should actually be thinking about diabetes is what's going to be killing most of the people in the world. I mean, in the next 20 or 30 years. So that's sort of one example. In terms of risk factors, so again, we've been really successful with tobacco, where it's not done yet, but we've been incredibly successful with tobacco. If you look at air pollution, and it's a little bit of I'm biased because that's kind of where I came from. We're not doing anything close to what we did with tobacco. And if you look at household air pollution and ambient air pollution together, it kills more people than tobacco today. And so again, like, and water and sanitation, we're not done, but huge success stories. But there's still, and household air pollution, Melinda and I have worked on this challenge. And again, it's unfinished, but there is a pile of NGOs that have not only, still will happily take your money, but will happily take your money for interventions that don't work. So again, these kinds of things, there's lots of examples of that, and we're not making so we're also very clear that we don't make recommendations. We provide data so that people can use them to make those recommendations. So yeah.
There's so many ways that you could audition. And I'm wondering, are you talking about like the compound figures that were are you thinking about environmental injustices or other like structural problems?
Yeah, I mean, so one thing is first to analyze, which is kind of I'm sorry, God. Are you thinking about structural causes, more distal factors, I guess, rather than sort of the proximal causes? And so a little bit like the first question, one way that we address this is to just do stratified analyses. So if you can see, who is bearing that burden disproportionately, can give in. And so we already do that, but that's not quite your question. But that does really give you a lot of information about that. So if you can show that, let's say at least geographically, there is, the southern part of the U.S. is where, things are worse than the East Coast or something, that tells you something. Getting the data on race and ethnicity is very hard. So we like many institutions we have a large focus on trying to do things from that perspective. We have a whole group that's sort of working on that, but actually getting the data are hard. It's just not recorded. And we're I think seeing improvements. In like the US and Canada and a few other countries, not really seeing that many improvements. India, right? Like it's like politically, I don't know what to say. It's not very smart politically for the government to release that information, and that's true for a lot of governments. So that's a challenge. Then things that are more, and we do have a way. I got in this and I was doing like environment. I got saddled with diet, so I know too much about diet now. So diet's really interesting. So you can think about like let's see, what's an example? You drink a soft drink that's full of sugar, and that leads to a higher measure of plasma glucose, which is what's linked to diabetes, but other things do as well. So we sort of look at the pathways, the causal pathways, and then there's a lot of complicated math to try and say that how much of the glucose, which is linked to diabetes, so what's the glucose diabetes relationship, what's the soft drink to glucose relationship. So that's kind of at that level. And then if you want to go another level and say like poverty or education, it gets even more complicated. But we are starting to do that. We're just starting to actually bring in education, and also bringing in some genetics as well. So yes, but it's complicated, and even within the risk factors, things are going in different directions. So yeah, but so more people need to work on it. But, yeah. Do we need to get out of here or one more? All right.
We know a lot about those things, and then that lack of action. What are some, like, I don't know, how are we affecting us, like presenting data or presenting what happened in the past with COVID better?
Yeah, so first of all, I think the question is, what about how do you think about the future? And I said COVID wasn't, we weren't well prepared for that. And how can we be better prepared? So one of the clear things is to think about, so one of the things, for example, with COVID is we know that people with pre-existing conditions were more likely to have more severe effects. And that's true for almost everything. So understanding that is probably the most important thing. And so when I said, diabetes, like in the future, yeah. And we've had huge success with like heart disease. So, when I was a kid, it was pretty typical that somebody worked till they were 65, had a heart attack. They were lucky to live to 75. Maybe they had had a heart attack before they were 65 and retired early. Now, you don't really hear about too many heart attacks. People have them, they survive for 20, 25 years. Like we've become really good at that. And we know people are not dying at the same rates. And that's true everywhere around the world from heart disease. Diabetes, it's getting worse and worse and worse and worse. And so we need to be thinking about that now. Everybody in this room actually should be thinking about risk factors for diabetes of themselves and their family, and governments should be thinking about that. Dementia, same kind of thing. So these things, we're not going to make changes overnight, but using just where those trends are going. So we also have a forecasting team, and that's exactly what they're doing. And that information, so now we're not just saying what the health is today, but we're saying what our best guess with uncertainty is the health, again, by age, by sex, by country, in out to 2050. And that's where we're also putting in now climate projections, because we want to try and it's one thing to say like the world's going to get warmer, but from a health perspective, and there's lots of reasons to be concerned about climate change that have nothing to do with human health, but we want to think about health impacts. We also have to take into consideration that by and large the world is getting healthier. So the health impacts of climate today are actually going to be less in the future unless we let the temperature go completely out of whack. And that's important to know. So those kinds of things. And you think about the speed at which governments, I don't want to say don't act. You need a lot of time to do that. So, all right, I got to shut up, but thank you. Great questions.